Hello.
We are live.
Yes, sir. Can I start, sir?
Hang on, Priyanka. So very good evening to everyone, and welcome to all MOS members, all the residents studying in Maharashtra. And I welcome you all to the next PG program. Now, before we begin the actual program, I would like to, for the first time, request everyone to maintain 30 seconds of silence. At least it was a very sad day today. We lost 75 doctors amongst almost 254 members of citizens of India in the Air India 171 crash. And it's one of the worst crashes that we have seen. So just 30 seconds remembrance for all of them, after which we will start the program.
Good evening, sir.
So with this, I welcome you all again. We have two wonderful cases today pertaining to retina. We have Dr. Priyanka Mumle, who's a third-year junior resident from KEM in Mumbai, aptly mentored by Dr. Anamika Agarwal, professor and head of unit at KEM, and Professor Avinash Ingole, who's professor and head of department at KEM. We have another case which is going to be presented by Dr. Ketki Deotare, aptly mentored by Professor and Head of ACPM Medical College in Dure by Dr. Surendra Vadgaonkar sir. And of course, like our usual series, the entire session is going to be moderated by Professor and Head of GMC Aurangabad, Dr. Archana Vare, and the Secretary of Scientific Committee, Dr. Sumit Lahane. We have two esteemed panelists amongst us, renowned teachers and very kind individuals. Dr. Naresh Kumar Yadav sir from Narayan Netralaya, Head of Department of Retinal over there, a stupendous teacher, and a wonderful, heartfelt welcome to Dr. Arjun Ahuja sir. He is the director of Sadhu Kamal Eye Hospital in Mumbai and teacher to so many surgeons from not just Mumbai, but all over the country, including some of my mentors. So with this brief introduction, I hand it over to Sumit and Professor Archana to begin our case presentations today.
Okay, so good evening, everyone. And this month, we are celebrating the Retina month. And we'll have two cases today. And both the cases are extremely important from the exam point of view, the retinal detachment as well as the retinitis pigmentosa. So we will start with the first case. And the first case will be presented by Dr. Priyanka. And she'll be presenting a case of retinal detachment. So Priyanka, will you please start sharing your screen?
Yes, ma'am. Am I visible, ma'am?
Yeah, you are.
Okay. So, good evening, everyone. I'm
Priyanka,
Dr.
we cannot see
Priyanka.
the slides.
Okay.
Yes, Priyanka, we can see them now. So you can go into full screen mode.
Yes.
Okay, start.
Yes. So good evening, everyone. I'm Dr. Priyanka, JR3 from KEM Hospital, Mumbai. I will be presenting a case on retinal detachment. So here, my patient, 62-year-old female, came with the complaints of sudden painless diminution of vision in right eye, associated with curtains across the field of vision for 15 days. Patient is known case of hypertension on treatment since 7 years, and both the cataract surgery was done 10 years back elsewhere with good post-op vision. On further evaluation, patient denies history of floaters, flashes, trauma to eye, history of spectacle use, previous such complaints, and there was no family history of similar complaints. and no systemic connective tissue disorder was found. Further, we proceed for ocular examination. Best corrected visual acuity for right eye was hand movement close to face, PA was accurate, plano, and left eye it was 6-6 part with minus 0.75 sphere and minus 0.50 cylinder at 30 degree. Pupil reaction for right eye it was sluggishly reacting, and intraocular pressure done by GAT was 10 mmHg for right eye. Rest anterior segment examination was within normal limit for both the eyes. On slit lamp examination, in right eye, Schaeffer sign was positive. Both eyes were pseudophakic, and rest anterior segment examination was within normal limit. Further systemic examination also was within normal limit. On fundus examination, in left eye, media was clear. This blood vessel, macula, and fovea reflex appeared within normal limit. But in right eye, media was clear, a 0.3 CDR disc, pink, and well-formed disc margin, but there was an elevated, convex, corrugated, grayish, mobile membrane-like structure was found, involving all 4 quadrants, which was bullous in superior temporal quadrant with subretinal fluid, macula off, and there was a single horseshoe tear with plaque noted at 1 to 2 o'clock superior-nasally, involving 1 clock hour. On further evaluation, there was a tortuous blood vessel noted with wrinkled inner retinal surface and rolled edges of horseshoe tear. Fundus finding was suggestive of total rhegmatogenous retinal detachment with subretinal fluid, with macula off, with horseshoe tear, with proliferative vitreous retinopathy grade B. There was no any shifting fluid sign or traction run noted on fundus examination. This is the fundus diagram for right eye. We further did ultrasonography for right eye, which was suggestive of V-shaped hypoechogenic linear membranous structure attached to optic disc with restricted after movement, consistent with the finding of total retinal detachment. So, by the clinical examination till now, it could be exudative retinal detachment, but in exudative retinal detachment, the appearance will be more convex, smooth, and bullous, and in some of the cases, it might associated with shifting fluid sign. It could be a tractional retinal detachment, but it will be a concave in configuration, and traction band or fibrovascular proliferation will be seen on the fundus examination. Patient might present with complaints of diminution of vision, which will gradually and chronic. It could be retinoschisis, but retinoschisis will be smooth, transparent, and less wrinkled and mobile as compared to the rhegmatogenous retinal detachment. And OCT will show splitting of neurosensory retinal layer. It could be choroidal detachment, but in choroidal detachment, appearance will be more dome-shaped, smooth. And on B-scan, it will suggest double spike, out of which one will be of the retina and other will be a choroid, and which is not attached to the optic disc. So after ruling out all this, we made a diagnosis of right eye pseudophakia with total rhegmatogenous retinal detachment with subretinal fluid, with macula off, with horseshoe tear, with proliferative vitreous retinopathy grade B, and left eye pseudophakia in a hypertensive patient. Further, we plan this patient for 3 post-planar vitrectomy with membrane peeling, with gas oil insertion, with endolaser, with scleral band buckling, and cryotherapy. So here are some intra-op images I want to share. First, we did a scleral band buckling with 240 band, followed by cryotherapy, and then 3 post-planar vitrectomy with membrane peeling, with endolasers and silicone oil insertion. Thank you.
So good presentation, Dr. Priyanka. So congratulations to you and Anamika ma'am and Ingole sir as well. And I just wanted to tell you, can you just end your slideshow?
Yes, yes.
So I just wanted to tell you that you've missed on some points, like after your negative history, you have to tell us about the past history, treatment history, and the personal history that you have missed. And after personal history is the end of histories. And after personal history, you have to tell us about general examination and systemic examination. After systemic examination, you have to start with ocular examination. So this is the protocol that you have to follow in your exams because you have 50 marks for your cases. Second thing is you have missed the diagnosis of compound myopic astigmatism in the left eye. And the animations and the transitions, they are not necessary when you are presenting a scientific presentation. So with that, I'll go to Yadav sir first, and I'll request Yadav sir to ask questions to Dr. Priyanka.
Yeah, Dr. Priyanka,
Yes.
what are the, did the patient have history of flashes and floaters?
If patient present with the history of flashes and floaters, there might presence of retinal break, which might associated with posterior vitreous detachment. Sir.
Okay. What is phosphenes?
Yes.
Is there a term known as phosphenes? You can see a flash of light, or if you press the globe.
Yes.
In RP cases, can you get flash of light or flashing of light in cases of RP, Stargardts?
Yes, sir. So we might get.
How? How is it possible?
In cases of RP, it might associated with posterior vitreous detachment. Then in such cases, we might found some patients with flashes and floaters.
Sometimes degenerating and dying photoreceptors themselves can lead to phosphenes. It's not necessary that they may have a vitreous related
Break or yes.
break, or that also is there.
Yeah.
And what is Linkoff's rule? Have you heard of Linkoff's rule?
Yes, sir. In Linkoff rule, basically, if there is a total retinal detachment, then in most of the cases, break will be
It has to
situated
be
superiorly.
it has to be total detachment only.
No, sir. There can be superior or inferior. In case of inferior detachment, if there is a inferior detachment with equal margin, the break will be situated at 6 o'clock. If it's with unequal margin of subretinal fluid, then break will be situated at higher side of the SRF. In cases of bullous RD with equal margin, break will be situated at 12 o'clock. But in cases of unequal margin, break will be on the higher side of SRF. In cases of superior retinal detachment, if it's crossing 12 o'clock, then break might situated at 12 o'clock. And if it's not crossing 12 o'clock, then break will be present at the lower of the subretinal fluids.
Okay, so that is important. You should be aware
Yes.
of the Linkoff's rule. And what are the chart that you showed? What is it known as? The drawing you did, no?
The Amsler-Dubai chart.
Was it correct? What you drew, the auras, serrata, serrations were okay? Serrations are seen in which quadrant more prominent?
So in a nasal quadrant, the dentate processes are.
What have you drawn? You have drawn all 360. It is seen equally.
I have no, so it closely spaced towards on the nasal side.
No, but I'm just talking about your drawing that you have shown. So temporal, sometimes it's very shallow. It's more prominent on the nasal.
Nasal side, sir.
Yeah,
Yes.
so that has to be drawn. And where is the equator located?
Equator is located at the vertex vein.
Any landmark, yeah, vortex veins. So buccal is not an option in this case. Scleral buccal.
Yes, sir, it can be.
So any indication where buccal is still preferred?
In cases of breaks which are situated more towards anterior or towards the ora serrata.
So this was there, no?
In this case, the break is somewhat at the level of equator. So we planned for both band buckling and
So
endolaser.
it was a posterior break.
Yes.
Okay. Well, what is dialysis? Traumatic dialysis? Have you heard of that?
Yes, sir. It is the avulsion of retina from the ora serrata, like from the
So
veins.
what is done in such cases? Buccal or vitrectomy? Traumatic dialysis.
So if the break is larger than 90 degrees or larger break, then we should go for vitrectomy rather than only band buckling.
You're confusing with GRT or you're talking of dialysis? What is GRT?
GRT is giant retinal tear, sir, in which the tear larger will involve more than 3 o'clock and or 90 degrees.
So traumatic dialysis, most of the time we do buccal. They do very well with buccal. Most of us, I think I agree. And in the slit lamp, when you mentioned about the PCIOL, what else you should see?
Any posterior capsular tear, I should see, sir, in case
Why it is
if there
important?
is
Why is it important?
in case of PC tear, the tamponade defect of vitreous we might lost in cases of eventful cataract surgeries, which might further leads to posterior vitreous detachment and causes break, might lead to retinal detachments.
Yeah, I agree. So basically, if there's a PC loss, PC rent during surgery, or the patient has undergone YAG laser later on, so this can increase the risk of detachment.
Risk of detachments, yes.
Any other problem during surgery that you can have if there's a large PC rent and you are doing vitrectomy?
While vitrectomy, the peripheral retinal break can happen, so this can cause retinal detachments.
That's fine. I think it is a little too too much for the at your level.
I request Dr. Ahuja sir to ask questions to Dr. Priyanka.
Yes, Priyanka, you did not mention whether the patient has PVD or there was no PVD. Hello, Priyanka.
Yes, sir. Yes, sir.
Patient had PVD or there was no PVD?
So in cases of retinal break,
Not
like
here.
only
In your case, which case you just operated?
yes, sir.
Priyanka, do you know what PVD is?
Yes, sir. But posterior vitreous detachment, it's
Ah.
normal. Uh,
So there are
normal change in the
more,
break
you get more chances of retinal tear when PVD is present or absent.
present, sir.
Ah.
Retinal break with PVD will be the predisposing factor rather than only retinal break or only PVD.
Yeah, so when PVD is in a blessing in disguise, once you have PVD, then
Yes.
there's no pull on the retina. Now tell me
Yes,
what's the difference between retinal tear and the retinal hole.
So retinal hole, in retinal hole there be a thinning of neurosensory layer, and which might cause hole. But in break, it's due to the traction. It can be due to the posterior vitreous detachment, or it can be due to traction band, which causes break.
Break, both are break. Horseshoe tear is also break. Retinal hole is also break.
Yes, sir.
The difference between the horseshoe tear and the retinal hole.
The retinal hole are mostly due to the degenerative changes in the
Yeah.
neurosensory retina, like thinning due to aging. And
Yeah,
the
so retinal
horseshoe,
hole is passive. Retinal tear is more dynamic and more active.
yes.
Okay. Okay, madam.
You want to ask anything, Dr. Priyanka? Do
Yadav sir, you can also ask questions to Dr. Priyanka.
no, I'm just asking whether she wants to ask anything, Dr. Priyanka herself, if
So
any.
I want to ask one question. Like in cases of retinal break, can we go for both band buckling cryotherapy with endoler, or we should go for like only one option will be sufficient for the treatment?
See, earlier we used to do a lot of cryopexy when the visualization systems were not very good. We did not have wide angle systems. So the periphery was not very well seen. That time we used to do a lot of cryopexy because cryopexy with the indirect you can see in the periphery. But now with the biome and the wide angle systems, whenever we are doing vitrectomy, we settle the retina and when then we do endolaser. Endolaser. But if the periphery is not seen, there's a small pupil, if the visibility is not good, then sometimes you can take help of cryopexy. But laser is always preferable. Laser causes less amount of post-operative inflammation. The RP release is less. So cryo, usually we do only when you are doing plain scleral buckling. We usually don't tend to do along with the vitrectomy.
Vitrectomy.
Priyanka, like Yadav sir said, that cryotherapy causes more inflammation. So what will happen with more inflammation? What complications can happen because of more inflammation?
A posterior vitreous retinopathy sorry,
We need
proliferative
to
vitreous
just correct the
retinopathy can
term,
occur.
the full form of PVR. It's proliferative vitreoretinopathy. That's
Vitreous
one of the leading
retinopathy.
causes of
Status post retinal detachment or
recurrent retinal detachment.
recurrent detachment.
Because what is a re-detachment? Now, how old was your patient?
She's 62-year-old female.
Right. Now, apart from conventional teaching, it is still surgeon dependent, of course. But why do you put a buckle? Why do you put a belt buckle? Not a scleral buckle, because a scleral buckle would be an entirely different surgical procedure. But why do you pull a belt to a 240 band belt buckle? Don't worry, take your time and think and answer.
Like for break is not visualized on the
But your break was visualized.
While if it's more curated towards the ora serrata and I'm not able to do the endo laser, then I will go for
Why would you not be able to do the endo laser? Or why would you not be able to shave the vitreous in the periphery? Because the patient is pseudophakic. No, it's a 62-year-old lady.
Yes.
You can easily take your cutter without the worry of causing a lens touch, causing further complications. So you should be able to do it with scleral depression. Doesn't matter what visualization system you use, whether you're using a contact system, whether you're using a non-contact system, a wide angle visualization system, you should be able to shave the peripheral vitreous. Why would you essentially want to put a belt buckle? That is my question, not in relation to this case. Why would you want to put a belt buckle? You're answering very well. You've answered most questions very well. Just think. It'll help you and others.
Like in case of small retinal detachment with break, we can go for a band buckling.
The reason you put a belt buckle is when you have, especially in patients, in younger patients. See, earlier it was put in almost all patients. But what happens is when you can't go too close to the vitreous, you're not sure you're going to be able to release all the peripheral vitreous, shave near the ora serrata. So when you have some amount of traction still over there, you're putting a belt buckle so that you reduce that traction. Okay. Now with newest MIVS systems, you're able to remove all the peripheral vitreous unless you know that in your surgical hands, you're not going to be able to remove all of it. So if you are confident enough of being able to remove all the peripheral vitreous, the entire need for a belt buckle is almost lost. Because again, it comes with its own complications. Yeah. So either there are surgeons who would stand by just a MIVS that is minimally invasive. Complete me.
Minimally invasive vitreoretinal surgery.
Very good. These were terms that we as residents did not know. So again, you can either focus on that, or you have MIVS plus belt buckle, like in your case, you all had done, or you can only do a scleral buckle also, which perhaps was also an alternative in this situation. We cannot deny that it was not an alternative, but you should know in your mind why you are doing what you are doing. Okay.
See,
yes, thank you, sir.
The belt buckle sometimes can be put if there is an inferior break.
Very good.
Multiple lattices, inferior break, because most of the time PVR happens inferiorly, because the RP cells will gravitate down and you get more PVR inferiorly. And multiple lattices, and where you feel that you will not be able to do a good vitreous-based dissection. Vitreous is very firmly attached at the vitreous base.
At the ora.
Yeah, ora and a little more anterior to it, posterior to it. So whatever said and done, sometimes you cannot really shave the entire vitreous. So if you want, it's a good idea. So you can still put belt buckle, but inferior in this break, when a single break, you could have got away without putting a belt buckle also. But if there are multiple lattices, inferior break, large breaks, then belt buckle could have been more useful. What are the other cases where the incidence of PVR is high? Which breaks or what age group?
Like the risk factor for the PVR are divided in pre-op, intra-op. In pre-op, the patient with high myop, patient with subretinal hemorrhage, vitreous hemorrhage are more prone for the
Breaks,
retinopathy.
breaks.
Large break. Yeah. And intra-op, if you use gas, PFCL, it might cause PVR.
Not PFCL, but I
Along
think
with
pre-op is
exaggerated
CD also.
intracautery.
If you have CDs preoperatively, caudate detachment, that also is a risk factor for PVR.
Risk factor for
Young age, GRT, large breaks, all this, hemorrhage, all these are there. Okay, fine.
Priyanka, you should begin this question with age, because the most common reason why you would have these situations is younger age patients who would have retinal detachment, because it's practically impossible to remove all the vitreous, no matter all the procedures that you add. The next would be not large breaks, would be a specific term called GRT, a giant retinal tear. These are the most two important indications over here. Okay, now what also Yadav sir also mentioned that you can, if there are inferior breaks, obviously not in your case, but there can be inferior breaks. So in that situation, you would want to put a belt buckle. Why? Tell me why.
In case of inferior break, we can go for pneumatic retinopexy. So,
Pneumatic retinopexy is a completely different procedure, Priyanka. Okay. You must read about pneumatic retinopexy, and everybody watching should also read about it. It's an entirely different procedure. See, what happens is, no matter what tamponade you're using, unless it is Densiron, which is not very frequently used, you have, or you're leaving PFCL inside, all your tamponades are going to gravitate upwards with time. Okay, considering their density. So in that situation, that leaves your inferior area unprotected. In that situation, you would want to keep a castle behind, like a fort behind. That is your belt buckle. Okay. Ahuja sir, anything else? And the other sir, anything else?
Priyanka, you had a superior break, right?
yes, sir.
So you will prefer gas or you will prefer silicone oil?
I will prefer gas, sir, because with gravity, the bubble will go up, seal the break, rather than
With gravity. What did you say? With gravity, the bubble will go up.
yeah, like compared to the oils, I will prefer gas.
That's
Sir,
about.
sir wants to know
In case
whether
of
it is because
superior,
of gravity or because it expands.
yes,
No.
it expands like
Yeah, what is buoyancy? Have you heard of the term buoyancy?
buoyancy. Yes, sir. Sorry, I'm mistaken.
Not gravity. Gravity will make it sink down, no?
Yes, sir.
Surface tension is important. Buoyancy is important.
Yes.
And what is the dilution of the gas? What do you use? You use pure gas or you use non-expansile gas?
We use non-expansile gas, sir, like C3F8 and SF6 most commonly.
Okay.
Just to correct Priyanka, we use all kinds of gases. We use expansile, we use non-expansile. I prefer expansile. There are surgeons who prefer non-expansile, mixing it and diluting it. SF6 is unfortunately used less in our country. We use C3F8, frankly, more. But you can tailor make your approach, whether you want to use SF6, depending on what type of cases. In macular detachment, in retinal detachments, the SF6 is comparatively used less. Okay. Now, I think we are at time limit. You answered very, very well. Very, very
Yeah, it's
well.
good.
Very well done.
So
Priyanka.
congratulations, Priyanka. You have answered really well, and congratulations to Anamika ma'am and Ingole sir as well. And
Thank
now
you.
we'll move to our second case, and it will be presented by Dr. Ketki, and her mentor is Dr. Vadgaonkar sir. And I'm very proud that I'm also his student. So, Dr. Ketki.
Thank you. Thank you.
Good evening, everybody. I'm Dr. K.P. Doctor, Junior Resident, ACPM Medical College, Dhule. I would like to thank Dr. Piyush sir, Dr. Sumit sir, Dr. Archana ma'am, Dr. Naresh sir, and Dr. Arjun sir for this opportunity. I'll be presenting the case under the guidance of Dr. Vargaonkar sir, Professor and Head of our department. A 49-year-old male resident of Shahada came to OPD with the chief complaints of diminution of vision in both eyes since 15 years. Patient was diagnosed all right 15 years back when he started experiencing painless diminution of vision in both eyes, which was gradual in onset and progressive in nature. Patient also complained that diminution of vision was more during night and in dim light rather than in day or bright light. There is also a history of peripheral vision loss, as the patient is giving history that he cannot see people walking past by him. Patient also gave history of tripping over objects during day-to-day activities. The differences for painless gradual vision losses are cataract, vitamin A deficiency, glaucoma, corneal dystrophy, macular degeneration, retinitis pigmentosa, diabetic retinopathy with maculopathy. Negative history: there was no history of night blindness during childhood, there is no history of frequent changing spectacles, and there is no history of delayed dark adaptation. Provisional diagnosis on the positive points based on history goes in the favor of retinitis pigmentosa. The positive points being painless gradual peripheral diminution of vision, night blindness, and tripping over objects during day-to-day activities. The differences for this case are vitamin A deficiency, congenital stationary night blindness, cortical cataract, open angle glaucoma, and pathological myopia. Family history: there is no history of similar complaints to any of his family members. Bowel and bladder for the patients are normal. Patient has no addiction. Patient went to different ophthalmologists in past years, but he was prescribed his spectacles. He was not advised any medication. There is no history of diabetes, hypertension, tuberculosis, or leprosy. General examination findings were within normal limits. Ocular examination: head posture was normal. Facial symmetry was maintained. Forehead and eyebrows were normal. Interpalpebral fissure was normal for both eyes, and position of the both eyeballs was normal. On slit lamp examination, lid and conjunctiva are normal for both eyes. Cornea is clear for both eyes. Anterior chamber is of normal content and depth in both eyes. Iris shows normal color and pattern in both eyes. Pupil is normal of normal size and shape for left and right eye and sluggishly reactive in both eyes. Pupillary area and the lens is clear. Intraocular pressure for right eye is 20.6 mm of Hg. That of left eye is 17.3 mm Hg. Vision for right eye and left eye: hand movement close to face, which showed no improvement with pinhole. Retinoscopy with topicamide was done, which showed minus 3.25 in both meridians for right eye and minus 2.50 in both meridians for left eye. Refraction was minus 4.75 spherical in right eye and minus 4.50 spherical in left eye. On indirect ophthalmoscopy, optic disc, size of the optic disc is normal, margins are clear, shape is circular, and color is darkly pale. CD ratio for right and left eye is 0.5 to 0.6. The cup appears circular. There is arterial attenuation present in both fundus. In macula, foveal reflex is absent. Hypopigmented patches are seen on the macula in two sides, and clumping of pigment is seen over macula. The retinal diagram, choroidal vessels are visible in both the fundus, and the fundus overall appears tessellated. The central retina shows bony cortical pigmentation, and the retina in the mid-periphery also shows bony cortical pigmentation. Investigations that were carried out was fundus photo. Fundus photo, both eyes shows waxy pale optic disc, arterial attenuation, pigment clumping on macula. Mid-periphery and the central retina shows bony corpuscular specules. Fundus overall appears tessellated and the choroidal vessels are visible. Perimetry was done on complete field analyzer, which shows advanced field defects, which which is suggestive of total blindness. Positive points from examination and investigations were visual acuity, which is hand movement close to face with both eyes, waxy pale disc, attenuated blood vessels, clumping of pigments over macula, bony corpuscular pigmentation in mid peripheral and central retina, and advanced field defects on perimetry. On the basis of history, examination and investigation, 49-year-old male is a case of bilateral advanced retinitis pigmentosa. Treatment advice, vitamin A supplementation was advised. Best corrected visual acuity with vaccine was given. Counseling was done to the patient. Patient was advised annual follow-up for cataract and glaucoma. Low visual aids were advised, and patients were referred to higher centers for further management. Thank you.
Thank you, Ketki. And I can see you are in dark. I think it's raining very heavily. Yeah, here also it is raining very heavily. Okay.
Yes, ma'am.
So very nicely presented case. So congratulations to Ketki and Bedgaonkar sir. And I request Dr. Yadav sir to ask questions to Dr. Ketki.
And Dr. Ketki, I just missed the slit lamp finding. So, is
Yes.
there any particular type of cataract that is more commonly seen in RP patients?
Yes, it is posterior subcapsular cataract that can be seen in RP.
Yeah, so that can be very debilitating. Already the visual field is constricted, and in the central, if you have PSC,
Yes, ma'am.
any other
Yeah, and the central vision can be. Yes.
finding in the macula that can also affect the vision? RP can be
There
associated
is
with-
cystoid macular edema, sir, associated. So that can affect the central vision more earlier if the edema is present.
Okay. And if this patient, you don't have I'll say the patient has advanced lung cancer. So is there any possibility that you can get a similar picture? Somewhat pigmentary retinopathy. Can you get? Have you heard of the term CAR, C-A-R? Carcinoma associated retinopathy? No.
Yes, I've heard about it, but
Sometimes
I'm not
patients
well
with
versed with it.
cancer, melanoma, they can also have pigmentary alteration, but it sort of develops over a short period of time. It's very rapidly progressive. And the fovea is spared. You get sparing of the fovea, and so
Okay.
diagnosis case DDs, you should be aware. And what all drugs can cause pigmentary alterations in the fundus?
The steroids can
Steroids?
cause alpha.
I don't think so. Okay, what can affect macula mainly? It is given for malaria, autoimmune diseases. HCQ, chloroquine, no?
Yes, sir. Hydroxy. Yes, sir. Hydroxy.
So what are the classical advanced findings that it is described as in the fundus? If you see that picture, bullseye, no? Bullseye.
Bullseye maculopathy.
So any patient with HCQ, you should be careful.
Yes,
You should, before starting. So there are various factors, but at least pigmentary changes you should, and any syndromic associations that you want to rule out in a patient with RP.
So there can be Usher syndrome associated with RP, but that that occurs in early age syndromic, and then there is rectum syndrome that can be associated. Then there is vessel conflict syndrome, and then and so there polysaccharidosis is associated with it, and Leber syndrome we need to rule out first.
Okay, one last. If you answer, then I'll be very happy. Why do you get bony spicules?
Sorry, sir.
Why do you get bony spicules? What is it constitute of bony spicules?
So that is migration of the pigments in the retina from the RP to the retina, the other layers of retina.
And they follow what? They follow the blood
They
vessels.
follow the blood vessels. They follow mostly the veins
So there's a
along
retinal thinning. The RP comes in contact with the blood vessels, and then they have a tendency to migrate along the blood
migrate
vessels.
around the vessels.
Good.
Thank you, sir. And Ketki, as sir has mentioned that there are so many syndromes associated with RP, you shouldn't have missed your systemic examination.
Yes,
Okay.
ma'am.
Yeah. So now I request Dr. Ahuja sir to ask questions to Dr. Ketki.
Okay, what is secondary RP? That was primary RP, no, retinitis pigmentosa.
Yes, sir.
Have you heard about secondary RP?
Yes, sir.
Now, whatever sir asked, all the reasons, they were all causes of secondary RP.
Secondary, yes, sir.
So why get confused? Acha, you get bony spicules on the fundoscopy, no? So it is more
Yes,
common on nasal side or temporal side?
Sir, it is mostly first affects the superior quadrant. Superiorly, it affects more. Then it migrates nasally and then temporally.
So nasal, it is more spread out compared to temporal.
Not that.
This is a congenital condition. No? This is one of the characteristic features. Nasal is more involved than the temporal side.
Yes.
Okay. What is Cuban's hyperbaric oxygen therapy? Have you heard about hyperbaric oxygen?
No, sir.
You've not heard. Any surgery to improve the vision in olden days we used to do?
So we can, if the patient is satisfied, we can.
To improve the function of the retina, any surgery, you know? Theory books you must have read, no? In olden days, we used to transpose the extraocular muscles and implant under the subscleral space. That was known as Thomas's surgery. Okay.
You heard of Luxturna?
Yes, sir, I've heard of Luxturna. It is a gene therapy which is given in if there is RPE65 gene mutation, and mostly it is given in Weber's congenital amaurosis because it occurs due to that gene mutation. It is an intraretinal injection in which we inject a viable copy of RPE65 gene.
Yeah, so one problem is that only 1% of the people have RP65 gene.
Yes,
There
sir.
are 400 genes involved. What is cell therapy? Cell therapy. You can inject RP cells underneath in the subretinal space, in the macular area. So cell therapy also is coming up. So trials are going on. So at least you should be aware of you may get a question.
Okay, sir. Thank you.
Kiki, what are the various theories of RP? As in for pathophysiology, what is theory of biotrophy?
Ma'am, RP is mostly degeneration of the retinal photoreceptors, in which the pigments migrate from RP to inner layers.
What is biotrophy? From where does this start? Which part of the eye?
I don't know that.
Sure. Okay.
Yes.
So it has relation with the embryology.
No. No, ma'am, no.
So the part which develops first degenerates first. That is theory of biotrophy.
Okay.
So where does it start? The degeneration, where does it start? No? What are the types of visual field defects that you see in RP?
Ma'am, we can see ring photoma visual field defect. It can be partial and complete. Mid-periphery, we see ring photoma, and it's mostly progressive visual field defect. We can see.
Have you heard of tubular vision?
Yes, yeah, ma'am.
So
Yes,
is it
ma'am.
seen in RP?
Yes, ma'am. Tubular vision.
Ahuja sir, would you like to ask questions to her?
What is mesos phenomena?
Sorry, sir.
What is mesos phenomena? Phenomenon.
No.
The color of the fundus changes when it is projected in the light. Then it will be reverse or direct. Not read mesos phenomenon. Which books you read? You read Luke Elder?
Nobody reads.
Do Kelder nowadays.
Acha, genetically how it is transmitted?
Sir, it is autosomal dominant disease. It is autosomal dominant recessive as well as X-linked. The most common type is autosomal dominant.
Okay.
And which is most severe?
Or X-linked.
Okay. Have you heard of electronegative B wave in ERG?
Yes, sir. But mostly in RP cases,
Yes,
ERGs are not recorded.
Okay, I know. In which conditions electronegative B wave is seen? Which diseases? You described those diseases. You said congenital stationary night blindness, X-linked retinoschisis. ERG is also important. You may get a question on ERG.
Yes, sir.
So multifocal ERG, ERG, electronegative B wave.
Yes.
What is atypical RP?
Ma'am, typical RP, in which it is associated with symptoms, or we can retinitis pigmentosa is there for typical RP.
When there is absence of pigments, what is the condition called as?
Retinitis pigmentosa.
What is sectoral RP?
In that, ma'am, only specific sectors can be involved. Like it can be specific quadrants, like it can be superior, temporal, or nasal. And with a better prognosis, it can be unilateral as well. Sectoral RP.
What is the classical triad of RP?
There is baxipale disc, there is bony cortical pigmentation, and there is arterial attenuation.
Can you tell us why do you see arterial attenuation, why there is baxipalar, and why there are bony corpuscles?
Ma'am, as there is degenerative stages as we proceed, there is degenerative stages in ganglion cell as well, which leads to decreased isoplasmic flow, which can give rise to waxy tail appearance of the disc. And due to degeneration of retinal pigment epithelium, the pigment migrates. Therefore, so there is a bony specular pigmentation in RP.
And why there is arterial narrowing?
Ma'am, the retinal pigment epithelium, there is a degeneration which mostly provides all the nutrition to the retina. So, their oxygen demand is altered, or blood vessels do not get enough of oxygen. Therefore, there is narrowing and system level.
Yadav sir.
Yeah, no. How does OCT look like in RP if you do a optical coherence tomography OCT? The patient has 6/6 vision, tunnel vision he has. If you do an OCT, how will it look? In the foveal area and in the parafoveal or little away from the fovea. You have OCT?
Yes, sir, we do have OCT.
What do you see in OCT in the case of RP?
So we look for if there is cystoid macular edema or if there is retinal membrane. For that,
That's fine.
most,
Anything else?
uh,
What happens in RP? You said no photoreceptors are lost. So
yes, sir.
what will you see on OCT? Read about the OCT.
Yes, sir.
What are the types of OCT? Time domain. You have time domain or spectral domain in the hospital, in the medical college? You're not aware.
No, I'm not aware.
OCT is, I think, all institutes have. So I think you should all be comfortable in OCT. At least the basics of the OCT. What is the principle of OCT? And the at least.
Yes, sir.
Ahuja sir, would you like to ask her anything?
So how will you treat the patient?
So firstly, you can give him best directed visual acuity with refraction. Then we can give him vitamin A supplementation, and counseling is important to patients of retinitis pigmentosa. And if the patient is willing, we can refer him to higher center for further management if he is affording and willing, and we can advise him low vision aid. If you want.
Ketki, as we have discussed the syndromic associations, can you tell us something about the ocular associations of RP?
Sorry, ma'am.
Plus minerals are important.
Yes.
It wasn't very
Yes, sir.
clear, but Ketki, with a lot of new research, just like Ahuja sir said, minerals are very important. I missed a lot of your presentation. I'm so sorry about that. But minerals are important, like sir said. And just to add on what little I heard from what the other sir said, is about OCT. Now, OCT is almost like a slit lamp examination now. And it's with time, it's only going to get more and more informative. So it is worth your while, not just yours, all our fantastic upcoming ophthalmologists. It's very worth your while to understand what kind of machine it is. See, I know it's expecting a lot from a resident because both you and Priyanka answered amazingly. But it's the more you learn at this stage, the more scope to learn in the future. So you should know about what time domain is. See, it's always important to know about the past, present, so that you can know what to do in the future. So in that situation, whether it's time domain, whether it is spectral domain, so in that situation, just read more about it. And did you all have a discussion about electrophysiology?
Yeah,
Yeah,
just
asked about the electronegative.
Correct.
only the ERG.
Okay, I leave it to Yadav sir and Ahuja sir and Varay madam.
They both have done quite well for a, but there's always a scope for improvement. Whatever facilities you have in the institute, you should utilize it fully. Whenever you use a system or you see the OCT, it should be a natural curiosity to see which machine we have. It's a spectral domain, time domain. OCT is very, I think, you cannot practice ophthalmology without OCT nowadays.
Very true, sir. Very true. And especially this is coming from people from much, much senior to me. When I can quote my example of not being, so, there were restrictions on residents of what you can use and which
When
year of
OCT came in 2006, so our management said, should we get it? Why do we need OCT? Yeah? We can see with the slit lamp. What else it will show more? You do a good plus 90, plus 78. So we didn't realize what all OCT will benefit it will give and what all can be picked up. ERM we never used to diagnose. VMT was not diagnosed. Shices MT was not diagnosed. So the whole of ophthalmology, at least retina, has changed after OCT.
So, Ketki and Priyanka and the rest of the people tuning in, it's important to utilize whatever you have and think beyond conventional wisdom and what we already know. Because I can quote from my own example. I forget about OCT. 90 diopter examination was something that was unheard of. And one particular person in my department was mentioned it to me, and I was immediate to jump onto the bandwagon to use something new and see what I can learn from out of it, including indirect ophthalmoscopy. And full credit to your teachers, your mentors, who allow residents to learn and experiment with all the points that Yadav sir and Ahuja sir and your teachers, your mentors, Vadgaonkar sir and Anamika madam. You're a very, very privileged, and I hope you all can bring more changes, innovate more, and always question why. Why?
And one more thing is they have, in theory, they have 4 papers. So second paper is optics and refraction, and the 4th paper is recent advances. So for that also, they need to know. I'm so exam-oriented teacher, but it is because they need it. So it is so important to know everything because you have to write 25 marks question on OCT and the mechanism of action, everything, and you have to draw diagrams. So you have to know everything about OCT.
Archana, I want to tell you that we
Yes.
have got all facilities in our department. Now we are recently purchased OCT Master 2, and then all students are there working on the machines. But somehow some basic they are not knowing. It is because of workload with them. But we have got all the machineries in our department, everything.
So we'll keep some
Congratulations.
master
So
classes.
I told them.
You must have given a free
Hello?
hand to all the residents. Use them.
Free hand. You know that they are using whatever they want to do, they are doing on the machines. I told them, even if it is breakdown is there, I will repair it, but you should handle it.
Yes,
So
that's
they
so
are doing
nice.
very well. Somehow, some basic they are not prepared for the basic thing sometimes.
No, so that's
No
okay.
problem, sir. Many
One
of
or
us
two.
are
That's
not.
fine.
And Ketki and Priyanka, you all are very privileged with mentors that you all have. But apart from that, always keep an open mind and question, answer. No matter if nobody can answer, search for those answers yourself. That is the only way out.
Right.
You all are going to fuel innovation. And with regards to what Sir said, is that basics can be missing. So we have master classes that I've started in MOS, and we'll cover OCT as well over there. So don't worry about it. Feel free to ask, learn, and question.
Yes.
Yes.
One should ask why.
Thank you so much for the opportunity, sir. Thank you.
So I think with
Thank
that,
you.
we will conclude the session. Before concluding, I would like to thank Dr. Yadav sir and Dr. Ahuja sir for your precious time and for guiding our students. Also, I would like to thank Anamika ma'am and Dr. Priyanka and Vadgaonkar sir and Dr. Ketki for the wonderful presentations, and our own Dr. Piyush Bansal for being there. So thank you, everyone.
Thank you very much.
Thanks, everyone.
Thank you.
Good night.
Thank
to
you,
Indore
everyone.
also
Good
for
night.
this wonderful support. And thank you, Sumit, for stitching everything together.
Yes.
Thank you, everyone.
Thank you.